That it?
Yes.
We go now?
It's Frank.
Supposed to.
That is my slide. I still have sound. That's my slide. It should be Frank. This concept of a lion was a genius idea. It's very unique.
Yeah.
And the lion is beautiful. The face. Yeah. Have you talked to Ophir when he talks about the lion? He's so passionate. Actually,
Are you gonna play or I go now? No. Oh, okay.
yeah. Yes.
Good afternoon and welcome to the Straumann Corporate Forum at this year's EAO, which features under the heading of Achieving Predictable Clinical Outcomes in Immediate Treatment Protocols. We very much appreciate you being here this afternoon with us. We realize this beautiful location offers many alternatives, and the fantastic weather would also invite to spend the afternoon outside in a nice tapas bar, but we really appreciate that you've decided to spend your afternoon here with us. I'm not only welcoming you here in the audience, but we're streaming this event live, and I would like to welcome the many thousand viewers that have joined us on Facebook to share with us this afternoon. We're recording the event, and you will be able to review it later on your website, where you will find the link to the stream. For more than 40 years, Straumann has been a key contributor to the advancement in implant dentistry. We have brought many innovations to the market that define industry standards and have allowed you to treat your patients in a more optimal and in a predictable way. Just to name a few of these innovations, let's start with the iconic tissue-level implant in 1986, which for many years was the most sold implant in the world and still defines the standards in tissue-level implants. This was followed by the SLA surface, the most copied implant surface in the world, cutting healing times in half. This surface was further developed into what we call S-selective, the only nanostructured hydrophilic surface in the market, further cutting healing times and allowing for more predictable treatment also in compromised patients. Another crucial example is Rock-Solid, our unique, strong titanium alloy, which allowed us to produce smaller, reduced diameter implants, allowing you to treat patients less invasively. This has progressed into shorter implants, so not just smaller, but also shorter implants, which again have allowed you to treat your patients predictably with less invasive treatment options. We've added a comprehensive biomaterials portfolio consisting of synthetic bone substitutes, allografts, as well as xenografts, and a full range of membranes. In 2015, finally, we've changed our iconic implant design and introduced the bone-level tapered implant, which paved the way for primary stability improvements, allowing you, for example, to treat the fully edentulous patient in a more predictable way. This portfolio was completed in 2017 with the 2.9 millimeter BLT implant, one of the smallest implants in the market with a fully functional internal connection and a full prosthetic range, increasing your treatment options also in very narrow interdental spaces. Finally, in 2017, we've completed our digital workflow range with a fully validated, integrated yet open digital workflow, both for chairside and lab application workflows. 2018, we've complemented the range with a two-piece ceramic implant, allowing for very aesthetic treatment options, as well as catering to patients that are looking for metal-free solutions. And finally, and most recently, in 2018, we've completed the range with the BLX implant. About you will hear a lot more in the following lectures. Our industry is changing fundamentally. Obviously, a no-brainer, digitalization having profound impacts in the way you treat your patients, starting from preoperative planning to prosthetic planning, but more recently, artificial intelligence-based diagnostic systems, as well as other applications that change the way you treat your patients, that change the way you communicate to your patients, the way you treatment simulate the outcome for your patients, and finally, the way you run your practice. New materials, such as high-performance ceramics, as well as polymers, in addition to additive manufacturing processes, change the workflows, change the way what you do as dentists, what your labs do, and what manufacturers such as Straumann do. So the entire workflow, the entire chain of work is changing. Another important trend is the formation of dental chains. We already have markets such as Spain, where 50% of all implants that are being placed are placed by dental chains. And if we think of the enormous growth in the dental chains and the high fluctuations, the educational needs to keep the treatment standards and the quality of the personnel up are enormous. So there is an enormous opportunity and need for educational activities. We're also seeing that the growth dynamics in our industries are changing. Whereas in the past, North America and Europe, that have reached quite high penetration levels, have been the key growth drivers. Markets like China, India, Eastern European countries are now becoming more important with respect to their growth contributions. And if you look at the list of participants at this year's EAO, China already ranks number 3 among the participating countries, and many other Asian countries follow in the top 10. So this also has implications on how we position ourselves as manufacturer. And again, these markets offer enormous needs and opportunities for educational activities. Last but not least, patient needs are changing. Patients are no longer just satisfied with aesthetic outcomes that are fully functional. They also want faster treatment, shorter treatment duration. And in addition, your patients are more informed, which also poses new challenges and opportunities for you. So this is jumping a little bit, apologies for that. In order to be able to address all these changing trends in our industry, Straumann has established a unique ecosystems of partnerships, and you see the different brands here. What this has allowed us is to complement our core skills in implant dentistry with capabilities and resources in the area of digital dentistry, so soft and hardware engineering, in the area of orthodontics, as well as biomaterials, and most recently, preventive dentistry. So we now own or partner with a unique ecosystem of brands and capabilities that allow us to serve you worldwide with best possible products and solutions across all these different treatment options. But let's get back to the topic of today, and this is really fiddly here. Immediate treatment protocols. Now, these procedures are a growing trend, not just because patients are asking for these treatments, but we also see that the clinical evidence for these treatments is becoming more and more robust, and the speakers later in the program will share their insights on this with us. If you look at the table, what you see here is in percent, the percentage of immediate functional loading procedures out of the total number of procedures, and you see that across all regions from 2019, where in Latin America already 22% of all the patients are treated with immediate functional loading protocols. This trend is increasing in all regions and will reach, predicted by 2023, roughly 1 out of 4 or to 1 out of 5 implant treatments in the respective region. So this is not a trend that we or you can ignore, and the question is, how can we best serve the patients in a responsible way in meeting their needs? Now, it's a great pleasure to introduce the moderator of today's session, Professor Waldemar Polido from the Indiana University School of Dentistry. Professor Polido is an oral maxillofacial surgeon, a clinical professor and chair of the oral and maxillofacial surgery at the Indiana University of Dentistry. He's also a very active ITI fellow, and it's my pleasure, Waldemar, to have you here with us today. Thank you.
Thank you, Frank. Thank you.
Do you have this one?
Yeah, yes.
It's really quick, huh?
So, good evening, everyone. Boa tarde. It's a really good pleasure to be here at the EAO, moderating this symposium. I have the easy task to present 5 unbelievable, amazing speakers. I want to thank Frank, Marcin, and the whole Straumann team for allowing me to be here and talk to you about introducing these speakers. So, today we're here to talk about immediacy, and now I understand Frank's problems. This is not working, you see. So, which one is controlling this? Maybe this one? All right, thank you. All right, so we're very happy to be here today talking about predictability and immediacy, how achieving predictable clinical outcomes in immediate implant protocols. Predictability and immediacy is the topic of the moment. You see Frank showed some data, and we want to talk about how to appropriate planning and use innovative techniques for immediacy. Now, nothing in medicine makes sense in the light of evolution, except in the light of evolution. So we have to evolve. The way osseointegration started many years ago, we looked at implant evolution. We looked at implant materials, design, finish, status of the bone, surgical technique, and loading conditions. That evolved through Professor Schroeder's research and evolution on still the same topics: material design, finish, host bone, surgical technique, and loading conditions. That moved away to an evolution of the surface techniques, how Professor Boozer and all the research that came after that influenced surface characteristics on bone integration of titanium implants. Then this evolution of surface, we'll see now where it's leading to us to achieve not only immediacy function, but also fast osseointegration protocols. And this is all documented throughout 40 years, 45 years of treating patients and looking at osseointegration. Then we look at implant designs. Frank already mentioned the implant design from external hexagon to tissue level, to the bone level taper, and now we have the BLX, which will be the main topic of our lectures today. And then we went into zirconia, into smaller diameters, into how these innovative surgical designs, implant designs, allow us to treat a larger number of patients with more predictability and less invasiveness. That evolved into the use of short, extra short, and narrow and extra narrow implants, all scientific-based evidence that we are used to work when we use these protocols and these products. And this is based on 40 years of history of developing this science behind all the materials we use today. Of course, abutments, how prosthetic connections work, how we can now tilt and angle implants, how we can now mill prosthetic components, how we can digitally plan everything, and through digital communication and allowing with this new surface and designs, we can achieve loading. So immediate loading has now a lot of time of scientific evidence, especially for fully edentulous static zone. Throughout this whole meeting, we saw a lot of evidence on immediate loading or immediate function or immediacy, even for aesthetic, for fully edentulous or for partially edentulous. And now digital technologies. If we walk around the exhibits, all you'll see is digital technologies. How do we incorporate digital technologies to capture data, to diagnostic and integrate, to do treatment planning, to execute, but also to follow up the longevity of the patients, the longevity of the treatment, and how we integrate and look at the outcomes. And we are now learning, integrating this digital technology into these new tools. So all these topics will be discussed today with this list of amazing speakers, because they will talk about evolution as a new perspective, an integrated framework, and then bring some intellectual coherence to this medical education of this world of implantology that we work on. So I'm very proud and happy to present all the speakers. Professor Eirik Salvesen will talk about planning to success, digital workflow. Erik's from Stavanger, Norway. We'll have our two friends from Lithuania, Algirdas Puisys and Tomas Linkevicius. We'll talk about surgical and prosthetic aspects of immediate implant treatment with emphasis on the BLX. We have Professor Blackie Swart from South Africa, maxillofacial surgeon about tooth in one day, immediate finalization of dental implant, and Professor Bedrossian from San Francisco, California, talk about on 4 or on 6 decision-making for full arch restoration. So please, Eirik, ball is with you now.
Thank you. I will do the other one. Thank you. I think I have this one. Is it? Thank you. Thank you, Waldemar, and good afternoon to everybody. We will try to spend the next few hours now making your time worth spending in here instead of staying at the tapas bar that Frank mentioned. And we will talk about basically all topics of immediacy. We will try to cover from the small areas to the big areas, from the single teeth to the full arches. My topic today will be immediacy in the aesthetic zone, and I will be talking mostly about, basically about case selection, and a little bit about how we do this and how we would proceed on doing it. So let's see if we can change some slides. There's probably some technical issues, but that's the topic of what I'm going to talk about. So planning for success, using digital workflow, and also trying to implement this into a minimally invasive surgery in our patients. There we go. So what are the needs of our patients? At least I'm coming from Norway, which is far up in north, but it still is basically the same need, I think, as the patients in your countries. Our patient is not in need of a new implant system. Neither are they in need of a new prosthetic connection. They're basically not in need of another implant surface. All our patients are in need of solutions. It's the solution that provides a better treatment, a more efficient treatment, and a more minimally invasive treatment. Because if we put ourselves in the chair of the patient, we always have to consider how much treatment is necessary to be done to achieve a predictable result. So if the solution comes out to being, I'll replace your tooth, very often the problem starts with, I'm going to lose one tooth, or I have lost a tooth. The clarifications coming from the patients will be, how are you going to do it? What does it cost? When you're going to do it? And how much time do I need to spend in your office? And how many surgeries do I have to spend time doing? And all those clarifications will, in the end, in a competitive market where patients will be informed enough to choose, make a difference in your clinical life. This is a Monday just before summer. This beautiful young lady comes into the office, smiling, but not smiling. And she's even a colleague of me in the office. And this is Monday morning, so she comes in 10 minutes ahead of her starting time at work. Lost one of her central tooth. And I reckon to be the people that I work with, I tend to look upon them as my family. So I will do the best choice that I can do for her as I would do with my family. And that's basically what we should do with our patient. So what are the choices to do with these cases? How can we treat this young lady and restore her normal function and her normal aesthetics in the most efficient way and the most predictable way, and basically with the best aesthetic result in the end? And we have a big toolbox. It's not like we're not doing 2 hours now to make everybody do everything immediate. We're trying to implement some ideas on some of your cases on how to treat them a little bit more efficient from the patient perspective. So the choices in these cases will, of course, they will depend on the information you can collect from these. And as you see on this case, you will have a high smile line. You see the case has an old trauma, so you see a reduced dimension of the roots. There was done a prosthetic restoration on this central 6 years ago. And when that was fractured now before summer, my question to my colleague was, do you want me to bond it back on? Because basically we can bond and see. And her answer to me was, I haven't been chewing on the tooth for 6 years because I was so afraid of it. To me, that's a disability in chewing. And I asked her, what do you want? You know, you perform these treatments, you know the patients, you know the perspectives. And she says, I want an implant. And then we look into how can we give you the implant? Or how can we give you a tooth on top of the implant, basically? So the considerations that we do when we pick and choose cases on the different treatment protocols will be teeth position. Is it important for the patient to have an immediate restoration? In the aesthetic zone, yes. In the posterior zone, maybe not that important. It's all about weighing up the benefits and the risks. Gingival margin is important. You're not gonna obtain a better gingival margin, it looks like that, when you do immediate procedures. Buccal bone needs to be in place, and we'll go through those factors. The position of the root within the alveolus or within the jaw is of utmost importance. The chance of obtaining primary stability is there. I will talk a little bit about what are the prerequisites to do so. And also occlusal control. We need to control whatever loading or forces that could be applied on a potentially temporary restoration. So let's go in to see how would I consider this one. This is a cone beam CT of my colleague, showing that we do have a gingival margin which is favorable. There is no gingival recession compared to the contralateral central. And that is important. That is one of the key, basically one of the key determining factors of when to go for immediate restoration in my practice. There's also bone buccally, as you can see. So there's intact bone buccally, and you can see the position of the root. That's why we always need to have these cone beam CTs when we do immediate procedures. We cannot guess. We need to know, is it a class 1, 2, 3, or 4? And if you started doing these procedures and you think that everybody's class 1, it's just a matter of time before you do your case number 9. And that's going to be a class 4. And your drill is out in the palate. And those of you working in these techniques know that that happens if you don't get the necessary information. So we have all of that information. Then we look to facial bony classification, or the bony defects. Is there a bony defect that will limit the potential of placing an implant at the time of extraction? Well, you have the classification done by the group of Professor Kahn, and those classified into from 0 to a V-shaped, to a U-shaped, to an ultra U-shaped. In this case, we do have an intact bone. So we have the bone, and we also have occlusal control because we have teeth on both sides, and we have a bilateral stability in the occlusion. You could say that you could align all these teeth if that is, what you prefer, but the occlusion is good enough. So it's stable, and we can control it. So we sum up those factors, and we see that we have a green light basically on all of them. There we go. The green comes. We have a teeth position that's important for the patient. We have a gingival margin that's favorable. We have buccal bone. We have a good position, class 1. We have the possibility of obtaining primary stability, given that we know how to do it. And there's definitely occlusal control. The next analysis that we would do in these cases is the aesthetic risk assessment, which you will find from the ITI sites. And it's important. I think this risk assessment is much more important for the patient perspective than us. It's important that the patient understands if there is challenges in obtaining the correct aesthetic result after the treatment. And in this colleague, there's one red, and there's a lot of greens, and there is some oranges. And that's a good one. And so we go on, and then we make our choices. So I've greened out a lot of the factors that was necessary to perform this treatment, and then I need to make choices. Do I go for an extraction and an early insertion or implant placement? Do I go for delayed implant placement, or do I go for immediate placement? And if I go for some of these choices, do I go for early loading, delayed loading, conventional loading, or immediate loading? And in my opinion, in these cases, my choice as a default choice with all cases until the opposite is proven is immediate. And there's a lot of reasons why not to do it, but you need to prove why not to do it before starting the other way. Because from the patient perspective, an immediate treatment will give a much more convenient treatment travel for the patient. What do I need then to provide these immediate solutions? It's not enough to have a patient. I need a lot more, and I need the companies, the industry, everybody to support us with refinements. We're now in Straumann Corporate Symposium. Straumann did not invent fully tapered implants. Straumann for sure did not invent immediate treatment protocols. It's been on the market for years. But what Straumann did with the new thing they introduced is refining it, building experience on their own system and looking what's the trend in the market, what do we need? And if you look upon that, we now have an implant design that gives us the possibility of adapt a drill protocol for primary stability in each case. We also got instruments in the cassette to do more advanced procedures. It's small things, but if you work clinically, you know that we need these small things. And also the connection, there's finally a pickup of an implant within this system. That's important because if we're going to actively insert an implant with a little bit more forces than we used to, we need a direct pickup of the implant. And to do so, we also need the toughest materials on the market to not fracture the implant when we are doing these procedures. And we also need a surface that will guarantee us not only primary stability, but also a predictable secondary stability that will develop due to a surface technology. Prosthetically, we need components. The worst thing that happens in the market is when somebody introduces a design of an implant without prosthetic connections or prosthetic components. And that has happened. If you've been in this market like me for 20 years, you know that it has happened very often. So what we need is prosthetic components as they launch the implant. What we also need is instruments to do is chairside, because it needs to be predictable to do these restorations chairside. We need it to be easy to adapt for a digital workflow. We need biomaterials because we need that in the aesthetic zone to provide predictable aesthetics. And in my experience, placing an implant surgically in an extraction socket takes me about this time. Doing the restorative temporization of the patient takes this time. So basically, it's time to do it on the prosthetic face. And you need to plan for that in your, in your schedule, in your logistics. So I click off on my colleague, basically all boxes green. It's a good case. So on a case selection-wise, I'm happy and lucky with my colleague. Everything's green. So let's see how we apply this information into going digital. We use the cone beam CT to plan in different softwares. For these cases, we use the co-diagnostics. And we also use the intraoral scanning by 3Shape, which in my opinion is the market leader in this. And then we combine this information in obtaining enough surgical and prosthetic information to provide a predictable both surgical procedure, but also a temporary prosthetic procedure. We need to plan, and if you know how a axis of a root goes into the jaw compared to where you're supposed to place your implant, this is basically the most important information that you can have in these cases, because you cannot follow the axis of the root. We're not placing implants in extraction sockets. We're placing them outside of the extraction sockets. We're placing them centrally, palatally. We're trying to find bone. We're not anchoring something in an empty space. With this information, we have the dental lab. Our lab will then make it what should be a shell for a temporary restoration. And you will see how it has wings. It's called the temp shell technique. It's done by others also. It just rests on the neighboring teeth to make sure that we will have this in the correct position. This temporary restoration will then be used during and after surgery. And this is just a minute video of the surgical procedure that we do minimally invasive. As we cut away some of the fibers, we do a careful extraction of the tooth. We use the pilot drill or the needle drill or the precision drill. So we don't use these round burrs anymore to make the opening in the cortical. And then you will find the same colors. If you're a Straumann user, you will recommend the 2.2 is the blue one, 2.8 is the yellow one. And then in this case, we will finish off with a new color. If you haven't seen it, if you're a traditional Straumann user, it's a white one. It's 3.2. And then we will, with a surgical screwdriver, and it's basically this big, manually insert the implant, because we will be changing a little bit on the axis of the implant to enter the palatal bone before we angulate the implant up. The same procedure we did with the drills. And when we have the position of the implant on the palatal, which you will see focused during the whole afternoon now, and then we have what we call slowly resolvable biomaterials. It's xenografts, and those will keep the volume of what is the aesthetic profile of the soft tissue. And you'll see also now a resorbable collagen sponge just put on top, just to keep like my prosthetic and restorative colleagues away from my bone. So that one's just a protective one. And it's nice that Straumann now developed these nice surgical instruments, even to pack biomaterials. So it's small refinements, but it helps in the clinic and it helps in daily work. So that's the case when it's done surgically, and then we move the patient or my colleague now into another office. And then we will start working on a temporary. And then the temp shell will then be produced pre-op by the lab, looking like this in acrylic or PMMA or whatever material you would like. It's just important that it has some opacity. It needs to be not that translucent, because then it will be grayish. And then we transform these. We do a pickup on the temporary abutments, in which temporary abutments we can pick different gingival heights. So we have narrow gingival heights coming in specific heights, so we don't push away the bone or don't touch anything. And that's another refinement that comes with the system. And that one is then adapted. It's done with the screw access hole, and then we pick it up, we refine it, and then we torque it in to about 15 to 20 Newton centimeters as a temporary crown. So choosing the correct temporary abutment is important. Emergence profile design, and there's no contacts in occlusion or articulation of these. They're non-loaded. They're just temporized. So let's look at how this worked out. This is my colleague's smile, same day smile. And this is from day 0, 6 weeks control, and at 12 weeks when the final restoration is inserted. Bone is still there. Okay, it's 12 weeks, but this is the same protocol we've been using since 2007 with different implant systems. And recently, during the last more or less 2 years, also now with the Straumann BLX system. So, what consequences does that have for my colleague? Well, it offers fewer visits. Okay, she's in my office every day, so that doesn't count. There's fewer surgical intervention, that counts. Less discomfort, that counts. Fixed tooth all the time, that counts. And more efficient treatment. And for me, as the employer of this colleague, it's less time away from work. Of course, it offers something. If I can provide minimal, the same result as I did when I did it conventionally, of course I should choose this. So, finishing off this one, I'd like to just give you some take-home messages. And those will be basically the same thing that I would traditionally say in my first slide. We do have primary goals and secondary goals of implant treatment. We should never try to risk the primary goals of successful outcome, high predictability, long-term stability, and low complication rate. But we should still try to challenge ourselves, providing more of the secondary goals to the patients. And that is the fewest possible numbers of surgery, low pain and morbidity during healing, short healing periods, and short overall treatment time. And summing that up, in my experience, immediate implant protocols offers great opportunities to achieve these results. But you also need to develop knowledge and clinical skills to do these procedures. Otherwise, the risk is too high. If anybody would like to get any of the information, any slides, anything that you need, please feel free to contact me by email. You will have it here. And I wish you, from this time and on, a very nice afternoon with the rest of my distinguished colleagues that will be coming in this area. And remember, we are in Lisbon, so please also enjoy. It's important. Thank you for your attention.
Eirik, spectacular, really good presentation. So now we have the pleasure of having Professor Algirdas Puisys. Did I get that right?
Yes.
And from Vilnius, Lithuania, and he will be followed by Professor Tomas Linkevicius, also from Lithuania, and they will talk about prosthetic and surgical components to achieve predictable results with immediacy.
Thank you very much for introduction, and thank you organizers for inviting me here. It's a huge honor to be on the stage. And my name is Algirdas Puisys. I came from Vilnius, capital of Lithuania, where I work and do research in my private practice. It's 11-chair clinic with a training center, and my specialty is dental implantology. I started in 2003, and since that, I have 15,000 implants placed in my career. Of course, I have a wonderful team, and one of the most important colleagues is Tomas Linkevicius. Thanks to him, I was able to publish and be author and co-author of more than 20 publications. And of course, it's a huge honor for me to be as a contributor of his new zero baldness concept book of surgical part. Today, my topic is immediate implant placement in aesthetic area. And you know what, dear colleagues? It was a very difficult task for me for many, many years to achieve the best result. And then I go back to 2006, to a year when I already learned a little bit to augment soft tissues, to do some bone grafting. I ended like this, with recession, with bad contour, color, etc., etc. And you know, yesterday we had a dinner with Miguel Stanley, and he told me very, very true story. So, you know, sometimes when we learn, we do something, and we work in small clinic, and get results like this, we feel very lonely and very disappointed. And I was also very frustrated at that time, because I wanted to achieve very good, very beautiful result, and I felt like a loser. And today I would like to share our story and our this 15 years way how we developed a strategy, or how to say just how to get this very good and very nice result and control the process. The first question was, should we go for immediate or for early implant placement? And I cannot forget one of my classmates. After we finished school, and she came to me and said, Algirdas, I know you are a good dentist, so can you help me? I need to restore 2 teeth. So, no problem, let's do it. I will extract it in 1 day, just put also temporous, immediate implantation, and also temporous at 1 day, and you see the result. So that time, I blamed only immediate implant placement, because I was taught by ITI. And 30% of cases end up with recession if we choose cases with thin biotype and thin buccal wall. And until 2014, I used only such cases for immediate implantation. Just when thick tissues were present, very thick bone wall was present, so it's a suitable case. But honestly to say, 2014, after ITI consensus paper was published, so of systematic review on timing, I was a little bit confused, because it was concluded that aesthetics may be achieved with immediate implant placement, but with the same time, recession is a risk for immediate implant placement. Then I looked a little bit more in detail to this paper. And you know what I found? That first of all, insufficient randomized clinical trials were added to the systematic review. It's one thing. And another one, that they were all very significant, very heterogeneous. So they were very different. What does it mean? It means that initial situations were different, with thick bone or thin bone, tissue biotype was different, biomaterials what used, if any used, and soft tissues were augmented or not. So it was absolutely different papers. We just put it in one pot, and really, we cannot take these conclusions to a daily clinical practice, because systematic review of such few papers, it's just like a direction, that we have some data on it or not. And also, some of my colleagues who used other brand implants said, Algirdas, you are old-fashioned. You drive old Mercedes by doing implants only early approach and not going by immediate. So when Tomas came to me and said, you know, Algirdas, you doubt so much about what time to use and when to place an implant, and let's make a randomized clinical trial and just answer for ourselves at least. What should we do? And we designed a study, so we have 25 patients in one group and 25 in another one. And this data is still not published. It will be next year. And we have already statistics. Crestal bone is absolutely the same stability. It's absolutely no difference between immediate implant placement and early implant placement. And aesthetic result is even better with immediate cases. So, and when we compare invasiveness for patient, there's, I think, no more any questions what to choose. And when we say this is difficult and this is easier, I say early implant placement. No, absolutely no. So, and it was also data what I could find that in comparison who compared immediate implant placement with early and grafted soft tissues together. So they found also the same or even better aesthetic result in the end of the day with immediate implant placement. So, starting 2014, our approach for immediate implant, for aesthetic rehabilitation in the aesthetic area, for single tooth, it's mainly immediate implant placement. Just by knowing this, that time is not the most important factor for recession, so we have to think how to achieve this stable result, how to develop this stable result from prosthetic point of view. And what we started to do, we just started to analyze successful cases. Of course, we have to learn from mistakes, it's for sure. But in the same time, we have to know where to go and how this successful case looks like, what we should to create and what we should to have to maintain this result stable. So, first of all, we have to have implant and bone around implant. And of course, fix soft tissues. And after, very beautiful restoration. That's it, just 4 consistent things. And here I would like to concentrate a little bit more to soft tissues. Yeah. Everybody agrees that bone 2 mm around implant neck, it's enough and it's already a good result. But what does it mean, thick tissues? As we're saying, well, we have to have thick tissues. And here, 10 years and 17 publications on vertical soft tissue thickness influence on crestal bone stability shows that we have to have at least 3 mm of vertical soft tissue thickness to maintain crestal bone stable. Otherwise, crestal bone will resorb because of establishment of biological width, and in aesthetic area, it may lead to recession. So, it's already clear, evidence-based, that 4 mm we have to have for vertical soft tissue thickness, and vertical soft tissue thickness maintains the bone. But then, if I place implant a little bit more buccally, I reduce soft tissues horizontally. So, how much I can reduce tissues horizontally, but still have the same vertical height? And when we draw this contour, you can clearly see that if we reduce horizontal soft tissue thickness, so the gingiva will go up. And if gingiva go up, so we have a less vertical height, so we lose bone. So we can conclude that horizontal soft tissue thickness maintains vertical thickness, and vertical maintains the bone. One more time. Papillas are hold on bone on neighbor teeth. And buccal soft tissue depends on horizontal soft tissue. Because horizontal holds vertical, vertical leads to stable crestal bone. 4 millimeter rule. So what is exactly what we see after immediate implant placement if we follow this rule? And this is what zero bonus concept all about. To get this 4 millimeter for buccal thickness, we have to place implant in a correct 3D position, what Eirik already mentioned here. And I remember also the day when I was in conference and my assistant sent me a picture and saying, you know, Algirdas, look, we augmented soft tissue, we did bone augmentation, and a prosthodontist destroyed our work. Look, what is the result? And I thought, you know, perhaps it's me, because of bad angulation. And despite I knew this already 15 or 20 years where to place implant and how the correct position should be, but the problem is that me, as a typical man, I cannot concentrate on two things. If I look for angulation, I lose primary stability. If I look for primary stability, then I lose angulation. So it means if I drill too much, so I can lose primary stability. But if I just drill with less drill, so I can lose my angulation. And here I found very good suggestion how to get primary stability, but also be in a correct angulation. So first of all, under-prepare the apical part and to prepare till the end palatal, coronal part. Because palatal bone is very hard, and if we under-prepare apical, we can be moved to buccal side. So, and it works basically with all implants, and I used to work with BL, BLT, and now with new BLX, it's even easier, and it's even better. But despite that, we have to prepare palatal side till then. Otherwise, we maybe move to buccal side. And can you imagine that only by 10 degrees moving implant, we will reduce the tissues in a half of thickness. So exactly what had happened for me in this case. So just always remember, we have to have this 4 millimeter at least for buccal soft tissue thickness. Also, suggestion was to use, in the literature we can find a lot of papers to use a small diameter implants. And some papers are saying that rock solid alloy is one of the biocompatibles, the most biocompatible, and also the strongest one. And by me personally, I feel very comfortable by using 3.3 or 3.5 or 3.75 implant now in aesthetic area. And here I would like to share one interesting case. Just tooth, lateral incisor tooth, was placed 11 years ago, and it is 3.8 millimeter in diameter. And central incisor was placed recently, new BLX 375. It's the same, almost the same diameter, but as you can see, the platform is smaller on BLX. And we have, again, 1 millimeter more for soft tissue thickening. So, and this will lead, again, to more stability of soft tissue. So we have a more stable soft tissues. After we placed implants in correct 3D position, after we used small diameter implant, we have a gap, and we think about augmentation. Bone or bone and soft tissue. And here we also realized during all these years that there are many classifications, and the patients who comes for treatment, they are different. So some of them, they have thick gingiva and thick bone. In that situation, we place implant, we do temporary crown. Crown should be as small as possible and just start to widen on the gingiva area, just very concave for more space for soft tissue grafting. But in cases when we have very thick tissues and very thick bone, we do nothing. we just leave like it is. Just the problem is that I don't have such cases. One in 10 years, maybe. Usually it's thick gingiva and thin bone, for example. Then it's a mandatory to augment the bone. It's no need to augment for augmentation, for soft tissue augmentation. And when we take some bone graft, first of all, I used xenograft. When I switched to allografts, it works perfect, but allograft cannot maintain the volume over the time that we see in our practice. So I came back to xenograft, and I've used BIOS for many years. And 2017, Straumann convinced me to try new Straumann xenograft, and honestly to say, it works perfectly. I don't see any difference. One more thing. I was also very doubt about surface, because SLA surface showed beautiful results. So it was no need for me to improve anything. It was maybe 1% of failures, early failures with SLA. But one paper convinced me. It was published by Frank Schwartz. It's in a dog model. We augmented bone around SLA and SLA active surface. And after 8 weeks on SLA active surface, we found 80% of surface covered by bone, by new bone. And on SLA surface, only 5%. So really, this paper convinced me, at least with bone augmentation, always to use SLA active implants. And finally, when we have thin gingiva and thin bone, what is perhaps most of the cases, at least in our country, in Lithuania, so when it's a mandatory to augment soft tissues, and graft from palate is a golden standard, of course, and it shows a beautiful results. After we place implant, fill the gap with a bone material, then, at least by myself, I was taught just to make split thickness flap and to place a graft in between periosteum and gingiva and secure it with 1 or 2 sutures. The grafts became smaller and smaller over the time, because in the beginning we started with a huge grafts with tunneling, and now we place in just one small piece. And one more thing, after we do this surgery, so we're waiting for beautiful healing, for beautiful emerging profile and texture and color. But if we elevate a split thickness flap, the graft from palate tend to grow. And over the time, we see differentiation. It looks ugly. So when we looked a little bit back to our studies, when we augmented soft tissues vertically and we placed grafts direct on denuded bone, we elevated full thickness flap. And also the same I found in the literature for and with recession coverage. When we cover recession, somehow we elevate full thickness flap in keratinized tissue area and place a graft on denuded bone. So that's why it couldn't work in aesthetic area. So since that, we started to elevate full thickness flap and starting to split only in mucogingival area and position it. And during all these studies, what we have done now, we see beautiful healing and no differentiation. Sometimes it grows a little bit, but no differentiation. It looks all the time beautiful, texture, color, etc. And of course, one more question. No one patient was happy with grafting from when we take graft from palate. We're always saying, okay, it's okay when you do implant placement and some bone grafting, but what you did with my palate, I never forget it. So I was curious, maybe we can use some other materials, for example, like mucoderm from company Puisys. I have been using it since 2010, perhaps, already 10 years. I've done more than 1,000 operations. And only recently, we just came to the idea to make a histological study, 20 cases. We augmented tissues vertical, and we got 1.8 millimeter on average soft tissue thickening in vertical dimension. So, and the histology showed also perfect results. No reaction as a foreign body, no inflammatory cells, good blood supply and nutrition, so it was everything very nice. Of course, now the question is, it's not evidence-based to use it in aesthetic area, so that's to also randomized clinical trial. So was again our idea, and we designed to study. It's not finished yet. I don't have any statistics, but I can share just pilot studies. if we need to thicken soft tissues, this material could be also suitable for such thing. Only one difference between mucoderm and connective tissue graft is mucoderm cannot keratinize. It's no keratinized wear. But in aesthetic area, usually we have enough of keratinized tissues. We need just to thicken tissues, so maybe it could help, but we need to wait a little bit for final results and to see a clear statistic on it. So with this, dear colleagues, I would like to conclude and to say a few take-home messages. So first of all, please have in mind that horizontal soft tissue thickness maintains vertical soft tissue thickness, and vertical leads to stable crestal bone. So 4 mm rule, keep the end in mind. To get this, we have to position implant in correct 3D position. So for that, we have to prepare coronal palatal bone till the end. Otherwise, we can be moved to buccal side. And with just a little bit, and then you lose this horizontal soft tissue thickness. And also, it's very, very important to make a concave temporary, just for more space for augmentation, and to place implant 4 mm deeper for future margin, or at least 3.5, because 3.5 is the limit in aesthetic area for biological width, again, to maintain crestal bone stable. And I come back because most of you want to photograph this. Please take a picture. So, and finally, dependent on initial anatomical situation, we have to choose a right grafting method. To do nothing, or to do just bone augmentation, or when we have thin gingiva and thin bone, bone and soft tissue. And only in cases when we have no bone on buccal wall, when we have inflammation, maybe then to refuse from immediate implant placement, or think about other approach like, for example, IDR. We hear today very nice presentation, or go for early implant placement. By having new devices, what industry, in this case Straumann, offers us, and following this 4 mm rule, we really are able to develop stable, beautiful results. Just now, I would like to invite Tomas to a stage and to share also ideas how to maintain this result, what we were able to develop. Thank you very much, dear colleagues.
Good job. Good afternoon. So I'd like to continue the performance of Lithuanian team, and as Algirdas nicely mentioned, that we just now to make a restoration, that's all. But it's not that always easy. There is actually one problem with this work when you receive cases like this. It is you need to work that not to destroy it. So how it's perfectly done, then every move you make with prosthetics would not harm this kind of nicely formed tissues. So what is the key to achieve this nice aesthetic result where we see now on the screen? What prosthetic things we must do in order to, to keep up with the perfect surgery which was done before? Algirdas has mentioned a little bit about our project, which we do, it's Zero Bone Loss Concepts, and it's a combination of different factors, surgical ones and prosthetic ones, how to achieve and to maintain crestal bone stability. But it's better to put in X-rays. When you see the 2011 and 2019, we don't even talk about bone loss. Like what we're talking about, we are having bone gain. So what things are important to achieve this kind of outcome? Well, from prosthetic factors, I would like to emphasize 4 things, which we will briefly discuss here. Connection, cement-or-screw-retained selection, what is most biocompatible material, emergence profile, and barrier base or height of tie base. How do these things match together, and what is the role of prosthodontist over here. So let's start with a connection that for why do we need it to be very stable? Well, we all know different connections, external, internal, open, closed conus, depends on our preference. However, what we have learned from previous two presentations is what you see. You saw immediate placement. And what is that? Implant is always subcrestally. And when implant is always subcrestally, then you have different environment than if we compare it to at the bone level placed implant. And we all know that when you see here on the video on your left that if connection is not stable, imagine this movement going on deep in the bone. So the deeper the implant is placed, the more connection stability is important. And like here, if connection is stable, you see subcrestal implant placement and really nice remodeling of the bone, reaching neck of the implant, but no bone loss, no bone resorption below the implant neck. And that's not always the case. When you see different systems and both implants placed below the bone, but in one case we see stable bone, remodeling and no bone loss, while the other you seeing bone loss. Now, there's a little bit additional procedure which we are taking during the surgery, actually after the surgery. Actually, I'm really glad that Algirdas is doing this because he's becoming a prosthodontist, finally, you know. After 15 years, he is on the right track. Well, so anyway, we do not really think about what we're doing with individual healing abutments because they are really better. Why? They provide a better stability. Because if we are using only healing abutment, all healing abutments have less engaging into our implant platform. That's why they are made. And we always have a better stability with the provisional abutments, which are usually used as a base for individual healing abutments. So that is also important to have a provisional crown or individual healing abutment in case the stability is not that good. But anyway, stable conical connection, platform switching leads to bone stability for subcrestal implants. Because when the implant is positioned, it really depends how the bone is reacting. If I would have to choose just a single thing, I mean, from all these 5 we discussed, I would choose cement or screw-retained restoration. Actually, I would go more for screw-retained restoration. And this is really was a big, my experience, and let's say this nice clinical case for many years, you know, we've been struggling to get the aesthetics, and this is probably one of the first cases which was done early placement, and we were really able to develop a nice soft tissue profile. We made a restoration, and for many years I was proud and showing this as a success. Now I'm showing this as a failure. Why? Because just look at the X-rays. 2009, 13, 18, it was a bad year. A bad year because we had, for some reason, perimplantitis. So just think, 8 years, nothing's happening. Patient does not even remember that it was treated. But you see problem. And the problem was very obvious. We removed the crown and you see semen remnants below the insubgingival part, not really visible on the X-ray. And not only semen remnants, look at the roughness surface of the abutment. So it means that this is an old gold casted abutment, so that's why these things are not biocompatible. So to finish up the story, 2019 was a better year. And you see that we have a bone remineralization. So of course it depends also on the quality of the implant and the quality of surface. So that's why we can expect these things if we really take the semen remnants away. The same patient, screw-retained restoration, no problems, 10 years. So if we have 4 papers talking about this clear decision, screw-retained, especially anterior region, And first of all, it goes into the direction of the implant. If you have a good direction, good position, it allows to make you screw-retained restoration, so you are already satisfying one of the most important prosthetic factors. What about emergence profile? Well, Algirdas has touched a provisional restoration, and of course, this is the key to develop a nice soft tissue profile to make the space for the grafting, and a really easy technique how to make it, just to using liquid composite before setting. Of course, the most difficult work then is to reshape the crown, to polish it sufficiently that it could be ready to deliver to the patient. So that's just the beginning of the work. Now, as you can clearly see on this nice picture, you see that there is a tunnel of the tissues, and then the tissues go wider. So that's the shape of provisional restoration given to the shape of the tissues. And remember that we will come back to this tunnel when we talk about tie base height, barrier base height. But of course, you see this space where we'll have the tissues. When the tissues are healed and we are making final restoration, that's another story. Then you can apply a little bit of pressure, because you need support. You need support for the tissues, because without it, it would be difficult to achieve adhesion, and we'll talk about that when we'll discuss biomaterials. If wrong height tissue T-base is selected, you can see what happens. You see nice bone above the implant neck, but too low tie base. This is just poor prosthetics. This is just poor understanding, because a prosthetic rehabilitation of subcrestal implants is completely different from those who are placed at the level of the bone or above the bone. And this is really important, as I said, when we talk about immediate placement, because all implants are subcrestal. So no doubt that in case like this, you see how wide and how low tie base is. We have bone loss, as we can see here. So when people ask me, how do I choose system which I work with? I always them, don't look at the implant in the beginning, look at the prosthetic things. So look at tie bases, how different tie bases height you have. So that's one of the key issues which allows me to select the implant system, because I know that I will be able to restore nicely different implants, different position of the implants. As then you can see here that the tunnel made by provisional restoration should be occupied for the tie base height. So the deeper the tunnel, the higher tie base in the gingival part should be selected. And of course, this tunnel gives you the chance of the implant placement depth. What is also important, that even in the provisional stage, we would have a different soft tissue height, gingival height. And here, it's a real case. You can see the all implant, all the part below the bone should really contact the tie base. Now, one of the final things what we need to discuss is, of course, biocompatibility. We cannot just talk about tie bases or different things without touching the material from which the crown will be made. And I want to just show you a little video about here, that the situation was here that we had to remove the implant due to the failed immediate loading. And with that loading, we saw that some tissues were adhering to the multi-unit abutment. And then we removed this abutment. And you can see that actually all our tissues can be divided in two big zones. We're talking about the adherent zone, the zone where we want to have some sort of contact or some sort of attachment, I don't know, some sort of a gluing of the tissues to our prosthetic restoration, and plaque zone. So this is really, why do we need thickness of the tissue? Algirdas was talking about horizontal, yeah, but of course it's important to have vertical, because we have a chance really to increase our adherence zone. Maybe there is a material which really can influence the strength of adhesion, that to be difficult for the tissues to detach from certain kind of material or restoration, and that would strengthen our protection. And also this is very, I think when I saw this video, it's like an explanation what is biological width. You see two distinct zones on abutment. Plaque zone, contamination, where there is no attachment, nothing can happen there, and clean zone, where you can have adherent zone. So that's why it's important to have tissue thickness, but also think of this, why it's important for us to select the material. And this is our goal, to have adhesion, to have almost no sulcus. Tissues really are glued to the surface of abutment and restoration. This is the implant restoration. Of course, this is one of the best cases. Come on, you try to show where we have the best. But when we compare different materials, you can find that, for example, here, different in tissues contact to zirconia and tissue contact to glaze or metal ceramic. While we sometimes remove the zirconia crown, we can see remnants of the tissues on the crown. While we can sometimes remove metal ceramic restorations, you find the breakfast or supper of the patient. So that's the difference, and these materials we can control and choose. What about biocompatibility of zirconia? And because, that's no question. Everybody is using it, and that's the material of choice. This is the case, it's 10 years old, which convinced me that we must work with zirconia and do research in that field. Because after the cementation of the crown, 10 years ago we were still doing cemented, you see a gap which was produced because we had supragingival margin for abutment. Now we do it on purpose. At that time we were really not doing that. And you see, after half a year, patient came back and there's no zirconia. The tissues have crept up and closed it. This is how it looks after 10 years. Excellent. You almost want to kiss those tissues because they look really efficient, quality, and look at the bone stability. What will happen to this implant? Nothing. I mean, it really will stay there forever. Different things why zirconia is really unique material. Structure, low adhesion of bacteria, vice versa, better adhesion of fibroblasts or epithelium cells. But from my point of view, the best quality of zirconia is its polishability. That you can see that from the rough status which we receive zirconia from milling center, it can be smoothed to the mirror-like, glass-like surface. Now, of course, it's a discussion. Do we need to have it so smooth? I mean, because there are different opinions. I mean, some researchers say that you need to roughen it to have a better attachment of the tissues of the cells, imitating something like a cementum on the tooth. But I think that the bacteria will be faster than your cells, and you will, with rough surface, you will have a better adaptation of the bacteria, not on the tissues. Remember what we have seen on the video with rough golden abutment, and it also influenced the periodontitis. So what I see around our super polished zirconia crowns, I see a great adaptation of the tissues, and I all invite you to do a just simple test, an ear blow test. You put a ear near the sulcus of your crown, and if it's polished zirconia, you will see that when you press it, it's not lifting. The tissues are not flabbing and really have good contact with the crown. So that's the power of things of polished zirconia. To visualize it, and when we'll talk about what cells are important to achieve this adhesion, this is how porcelain or glaze looks under magnification and zirconia. And when we find out that actually epithelium are our protective cells, and we must talk about, first of all, epithelium cells which line the surface of the abutment, not connective tissue, not fibroblasts. Fibroblasts are located below 1 millimeter above our implant level. And we all know that epithelium really likes the smooth surface. So when you combine smoothness of zirconia and smoothness of ceramics, you can really explain this. Now, how to maximize the contact? I mean, if zirconia is good, how do we maintain this tissue stability which was developed by the perfect surgery? Maybe a stupid question, but you can have different restorations. Like zirconia without zirconia restoration, when all zirconia is hidden inside and glazed by porcelain, or real zirconia ceramic restorations, where you should see a clear mark between zirconia and ceramics or emax or glaze. It's a matter of your choice. So you can nicely see here, this is correctly made zirconia restoration, because this part will be below the tissues and will have real adhesion or chance to develop adhesion, because without that, we don't have a chance to have it. And developing all this because starts from the wax up, and more, we sometimes go back a little bit in time and technicians do manual waxing to prepare the framework of zirconia, because then we must really stay strict on the surface, how zirconia deep is below the tissues. What effect it gives, delivery day and years follow-up, you see a nice bone stability. And of course, I'm not going to say that it's only zirconia's fault. No, there's a process, there is a different things, but if you compare delivery day and 8 years follow-up, you clearly see better bone stability with time, and I'm sure that zirconia has played a role over there. Now, there is a very interesting research coming from Belgium, and I always cite it and always show it because it really is in alignment with why I'm talking. So the idea of the research was that after half year of function, researchers have removed the restorations done in a similar way, tie base, polished zirconia and ceramics only on top for the aesthetics, and they looked what kind of cells do they see at the surface of zirconia. And guess what? They found epithelium. Epithelium is a protective cell which really glues to the surface of the material. And if we have zirconia and polished zirconia, for the epithelium, it's much better than the rough surface. So we have the adhesion of the fibroblasts just 1 millimeter above the implant, above the bone level. And you will see what amazing things really polished zirconia can do to the tissues. Immediate case, provisional restoration, final restoration, and you see with time that the tissues are getting better. So you see the rim of attached tissues increasing, and that again gives you a perfect bone stability. Another case, you see, almost you need soft tissue graft for this, but we restored the restorations with a zirconia, polished zirconia, and after 1 year, I'm calling Algirdas and saying, hey, we don't need soft tissue graft. I did it by myself. So with this, I would like to summarize 5 things: stable connection, polished zirconia, gingival height of the tie base, concave profile of the final restoration, and that really gives you the final, diamond in all the story, perfect restoration and perfect soft tissues. Thank you very much.
That was amazing. Really good performance from our Lithuanian team. Congratulations, guys. That was awesome. Very tough act to follow, but we have a star from South Africa here, Professor Blackie Swart. We'll talk about the one tooth, one day, one everything. So, Blackie, to you.
Thank you, Waldemar. Ladies and gentlemen, you've been listening to a lot of literature until now. Let me tell you a story that came up in South Africa in the last week. There was a guy who had a lion, like Tarzan, and he put his head in the mouth, and the lion was absolutely tame. Until one moment
that that lion's instinct came back. And the handler was killed last week. So the nature of the beast never changes, nor do we as humans. Because if we look at this, one tooth, one time, and if I could have the correct advancer.
Maybe it's the other one.
This one was probably. No? Is it this one? Ah, it's the third one. Okay. That's it. Okay, so our needs as humans do not change. We, and I'm not talking about they, because they are patients. I'm also a patient at times. I want less chair time, and if I'm the dentist, I want to spend my time as efficiently as possible. That is our needs, and that is the why of my talk. So why do we look at immediate restoration of molars? There's enough papers published in the literature to have a literature review study on random controlled trials about it. And the result of this New Zealand group was that there was 188 implants with encouraging results. So am I the first one to do this? No. No, Ed, I'm not. It's already been researched. And let's go and look further at the Dion of the ITI. We go and look at Lang. And Lang already, in 2004, looked at this problem with 67 patients. And in normal Straumann parallel-walled implants, in 1 week's time, it was retorqued to 35 newtons. And 1 week later, at 2 weeks, when we know bone morphology is at its lowest, the crown was seated. I hesitate to think of that. And then when it was asked, is this new? No, definitely not. And you know what they found? There was no difference between 2 weeks and 6 weeks placement of the final restoration. And these were porcelain fused to metal crowns at that study. So another study from Lambert, One Tooth, One Time, was published in 2017. And then our own technique was also described this year. So that is the why. And now is the question, how? And here is one of the reasons how. We are on a journey somewhere, and this is one of the reasons how. And then Straumann BLX was brought to us. It gives us the stability because of the way it was functioning, because of the design of the threads climbing into the bone. We've got versatility. We can use it in small diameter implants, the 3.5s, to, I only go as far as the 5.5, but the versatility is there. The options are yours. We've got the confidence. Why? Because of the literature. The literature tells us is the SL active gives us a superior osseointegration. We have confidence in the rock-solid material. And now, with the digital flow, we can make it shorter and more predictable. Thus, I and we, as patients, can benefit from this journey. So let's go and look at the study that was done. It's not a study, it's actually clinical case collection. So from the digital planning on co-diagnostics, a surgical procedure was done, digital flow and milling, and then a crown was seated. So the aim of this case collections was to do a clinical case collection, and the question was asked, is it predictable to use BLX with a definitive restoration in the molar region in 5 hours? Can primary stability be achieved in most cases? And does digital flow allow for the crown to be placed within 5 hours? Not a full day, 5 hours. So the patients that we collected was all from my private office. It's the real life. It was consecutive patients, and it was a prospective study. I did not have the know-how or the happy ending of a academic situation where it could be a very sterile situation. These were following patients, 8 following patients, and they were all determined for surgery within the next 3 months. We did it in 2 days. They all had a single missing mandibular first molar, so it was healed sites, opposing and adjacent natural teeth, and it was balanced occlusion with no posterior interferences, and the teeth on the opposing side counteracted an unbalanced occlusion. I did 8 following cases, 5 females, 3 males, aged between 31 and 62, with an average of 51. I used 4.5 and 5.5 millimeter implants, all 10 millimeters in length. And that is what they all look like, from class 1 to class 4 bone. Primary stability was achieved when it was above 35 Newton centimeters and a higher value than ISQ. In soft bone, it was underprepared, so surgical biological feedback was needed. In soft bone, and that was in most of my cases, the 2.2 millimeter, you needed to gently take it in because you get your biological feedback from that drill. Because if you hit the lingual plate, you can feel it. So it's not a rigid way that you go in. It's the way that you touch your wife's hair, how you go in, like that. And on that, you determine which subsequent drills need to be done. The cortical bone preparation is extremely important because the cortical margin, if you put that implant in and the bone blanches, you know you are already in trouble. It's not you're going to get into trouble. You are already in trouble. And the medullary bone preparation depends on your biological feedback from your first drill. Because the study shows that if you go above 55 Newton centimeters in your cortical margin, you are going to have dishing and you're going to have problems with your cases. And as you can see here, in the first case with a class 1 bone, you can see the preparation all the way to the end. In a medium density bone, you can see the preparation in the cortical bone, you can see the medullary bone underneath, and in very thin bone, only the cortical margin is prepared. All of the rest is compacted and compressed by the BLX implant. So, just to run through a quick case report, all of the drills in sequence, you will always see a little bit of an under preparation, and there's the implant. That is a 5.5 millimeter being placed with the margin of the implant just below the cortical margin. And that is the end of it. In the laboratory flow, a milled prosthesis is made with a variobase that is cemented outside of the mouth, and that is what the final prosthesis looks like. That was going to be placed within 5 hours. And all of these implants was placed in occlusion. But you must remember that in a definitive restoration, you must always place it with a little bit of a lighter occlusal force, because a periodontal ligament, the tooth can move in and out, especially in a bruxer, whilst an implant, which is rigid, cannot do that. That's why the marks on the implant is a little bit less than that on the adjacent teeth. And that is what it looks like post-op, 6 months and 9 months. And I was astounded, because things don't change. They stay the same. And look at that. That is 9 months of follow-up. So now I challenge you. This is all my cases. I do not show one case and talk about the rest of my collection of cases. I show you them all. So all of you pick one implant, and I will show you through it. 6 months later, look at that implant, just that implant, and look 9 months at that same implant. And now I'll take you back. Take another implant. Don't look at the same one. And we go through it again. That's 6 months. And that is 9 months. And in that, there is no dishing. This is consecutive cases. This is not retrospective study. This is prospective. You show me one case with dishing, and I will give you a prize. But who of you noticed case 2? Just quickly. You noticed case 2. I also thought that was a problem. Why was it placed so deeply? But let me show you why. Because of the difference in the cortical margin. On the buccal, it was lower, and therefore that implant was placed there. And yet, the bone around that implant stayed stable for the full 9-month period. Look at that. Placement up to 9 months. So I'm showing you all my cases. I'm not selecting one and giving you certain results. So the results. Primary stability with an average of 52. ISQ of 74. 5 implants were underprepared, with 4 of these sites only preparing the cortical margin and using the implant and the medullary bone to get primary stability. The full complement of drills was only used in a single case. And in that case, with a class 1 bone, as I went in, the torque went too high. I reverse torqued it and then went into the final depth. In the prosthetic, complications included problems in the contact and occlusal adjustments. No fractures or chips were noted in the 9-month observation period. One of the surgical complications that we had, as you can see the line crossing his eyes, was at the planning stage, the placement, and 2 weeks later, I was in Europe. My prosthodontist had removed the crown because he felt there was instability. So is that a problem? And was that a problem? Let's go and look what happened. Because at 12 weeks, when I rechecked the ISQ value, it was at 70. That same crown was placed in the same, on the same implant with the same contact. There was no movement. And that is what it looked like at placement and now at 9 months follow-up. Yes, we did have a complication, but it was no problem to sort out the complication. In the prosthetic parts, we had one case where the patient with an early placement case had a 2.5 millimeter variobase. She complained of food impaction, and the prosthodontist at the 9-month interval had changed the 2.5 to a 1.5 millimeter variobase, and our food impaction problem was solved. So thus, in conclusion, the one-tooth, one-time technique has shown to be a predictable and reliable treatment option with a Straumann BLX implant. The use of fully digital workflow, also for the surgery, would make it easier for less experienced people to do the same technique. The choice of the appropriate implant system is critical. A tapered implant with engaging thread design and hydrophilic surface facilitates a high bone-to-implant contact and osseointegration. Clinical experience is beneficial, especially in that first 2.2 millimeter drill when you get your biological feedback. New implant systems and digital workflow requires experience and familiarity. If you are an archer and you take out your bow and arrows, and you always shoot with wooden arrows, and for this one case, you want to take out your golden arrow and shoot with a metal bow and a metal arrow, you are going to miss your target. So your average implant that you place every day must be BLX to be able to do this study. A learning curve with a new technique and materials must be anticipated. A printed model to evaluate the seating path and context of the definitive prosthesis is beneficial. So, ladies and gentlemen, that made me decide after doing that and seeing this amazing results that the ideal for this technique is really in the premolar area. And you will see the digital planning where I use co-diagnostics with a pilot hole technique. Scanning is done and the milling is done, and at the end the crown is seated. The premolar is the ideal for one tooth, one time technique. And here you can see that case, how it presented pre-operatively, and then with the surgical technique I use a vegetable die to mark the precise position. I do then a roll-over flap, and the normal technique of drilling is done. But what I find is that additional soft tissue augmentation work must be done at the time of surgery, because you do not have the opportunity to come back and back and back again. So it's best to do all of this. And here you can see I had a dehiscence that I augmented with bone at the same time. And it was a milling, and as the prosthesis was placed, you can see the blanching against the rollover flap that I did. And there's the full occlusal contact of that premolar. And this is 4 weeks later, and this is actually the brother-in-law of my prosthodontist. And 4 months later, that is the result. So before and after. And this could be done in 5 hours. Just think of what this can do to your patients. So one tooth, one time, a premolar, final in 5 hours. But now we use full digital flow because we're going to do it fully guided. With digital flow and milling, the final crown is done in 5 hours, and it's more predictable, especially for somebody that doesn't do surgery that often. And remember, there's smile in the box. If you do not have the capacity or the fees to have your scanner and to buy a scanner, you can all send it to this cloud, and they will do all your digitizing for you and send it back to you. And this is what the case looked like. She came into my office looking like that, full digital surgery, and she walked out with a broad smile. But here you can see, with the fully guided implant being placed, I had to do a little bit more soft tissue work as I cut it out of the palate and transplanted or transpositioned it to the mesial to get a better pupil, as you can see in the bottom left-hand side. And my time is just up, and I said I would take only 20 minutes. Thank you very much.
Awesome. Perfect, Professor Stewart. So we saw aesthetics, we saw zero bone loss, we saw minimally invasive grafts, we saw posterior region. And now, last but not the least, Professor Edmond Bedrossian, our maxillofacial surgeon from San Francisco, will talk about the immediacy for fully edentulous patients. Professor.
Thank you. Thank you very much. It's my pleasure to present at your 10th hour of continuing education all in one day. So thanks for your stamina and staying, and I hope I will add something to your existing knowledge in talking about the fully edentulous patient. The task given to me was to present the science behind 4 or 6 implants and how do we choose that. But you know, it's good to think for a second. We went from 2-stage delayed loading to 1-stage immediate loading. That's quite a transition. And how was this possible, and what was the motivation in the changes? And I think we all agree that improved patient comfort was one of the motivations. The fact that we shortened the treatment time is good for our patients. And I think the greater patient case acceptance comes along with the first 2 of these points. But we cannot forget what the gold standard is. Gold standard is the delayed 2-stage loading with a success rate of 98% or higher. So if we are modifying or moving away from that, then we better have the same or better success rate. And I think all of you will agree that immediate loading full arch cases has greater than 95% and sometimes even better than that of 2-stage delayed loading numbers. So why is there so much confusion if that's the case? And I think it has to do with the final prosthesis, confusion about what the final prosthesis should be. The biomechanic principles are confusing, and a number of implants. So basically, these 3 points summarize into treatment planning. Every case, whether it's single tooth or fully edentulous, has to do with treatment planning, and that's the barrier for a lot of our colleagues in not getting involved and having their patients sit around until there are much bigger problems before treatment is initiated. So hopefully we can clarify some of that. So we always start with the end in mind. What is the final treatment, the prosthesis? And we wrote this article at our residency program to help our residents, and it was so simple that it has been adopted quite, by many of our colleagues. What basically we're doing is we're taking an edentulous patient and we're looking at the occlusal plane. We're looking at the distance from the gingiva to the occlusal plane. If it is short like this, well, obviously this patient is missing a tooth, their crown only, like clinical crown. So we call this a tooth-only defect. But if they have a longer distance, they're missing teeth, bone, and gum. Well, that's a mouthful, so what we call that is a composite defect. So if you have a tooth-only defect or a composite defect, that's your first thing that you have to identify before we can even go on in treatment planning. So what does that mean? That means if you have a lot of bone and no resorption, you're going to receive a white bridge. Whether it's zirconia, PFM, it doesn't matter to me, a white bridge. You can have pneumatized sinuses, but no vertical or horizontal bone loss, so you still will get a white bridge. But if you have a composite defect where you're missing vertical and or horizontal bone, then you are going to have to replace the 3 tissue types, soft, hard tissue, as well as the clinical crown. But if you do this, obviously it will not be aesthetic. So we are now transitioning into hybrid prosthesis for the patients with a composite defect. And I think the advanced composite defect patient is quite clear that is going to receive a hybrid prosthesis. So it's quite simple. Are you missing teeth only, or are you missing teeth, bone, and gum, or you have a composite defect? Because here's a case with 4 implants and a white bridge. The tilted concept is usually associated, as well as the zygoma, is usually associated with a hybrid prosthesis. That is not true. It's just a surgical technique to achieve the final goal, which is the final prosthesis. In this patient, 4 implants for a PFM in the maxilla. For this patient, 6 implants for a PFM in the maxilla, but a hybrid in the mandible because the patient has a composite defect in the mandible and a tooth-only defect in the maxilla. But then you look at this patient who has dental alveolar extrusion and bone loss, definitely he's not going to receive a white bridge. So this is clearly a hybrid type of a prosthesis. So once I think we've mastered this, a lot of the confusion is relieved. So now we're ready to place our implants and we want to understand the biomechanics. The biomechanics was described by Skalak in 1983, and basically what he said was the number of implants are important, but more importantly is the distribution of the implants. The chair you're sitting on has 4 legs on every corner of the seat. That's not by accident, because that's the most stable configuration. So it's not the matter of how many legs your chair has, it's what's the distribution of the legs. The same thing with a full arch edentulous jaw. And then, if the seat is not screwed tightly into the seat, you have a very unstable chair. So the prosthesis must, at all times, be securely fastened to the implants. 5 years later, Bo Rangert said that distribution of the fixtures along the curvature of the arch is important. They are ensuring proper fit of the abutments and maintaining the tight fit of the abutments. Basically, exactly what Skalak said, just different wording. And then you fast forward to 2014, and John Brunsky basically said essentially exactly the same thing in the European Journal of Implantology. So it's quite evident that three people who sort of knew each other, or maybe did not know each other, when they say the same thing, there's a lot of credibility in that statement. So having said that, how many implants do we put? And we just said that the distribution is just as important as the number of implants. Here's a study of the lower jaw. What they did was they looked at the stress on the prosthetic structure, they looked at the stress at the bone implant level, the so-called saucerization or crestal bone loss, and then they looked at the stresses within the bone. In other words, the osseointegration of implants. What they did was they had 5 traditional Brånemark vertical implants in between the mental foramina. They took the middle one out. Then on the third model, they distributed the remaining 4 evenly. On the fourth model, they had 3 implants, and on the fifth, they had 4 implants with a 17-degree tilted terminal implants, and then 34-degree tilted terminal implants. So these were the 6 models that they were working on, and they looked to see what is the difference. Regardless of how many implants you have in a jaw, whether it's 16 implants or 4 implants, it's always the distal lingual of the terminal implants that take the brunt of the forces. So it doesn't matter how many implants, it's always the first one and the last one that take brunt of the stress in centric loading. And what they saw in this distribution was the least stress, both at the prosthetic, at the bone implant level and within the bone, was with the 34-degree tilted implants that were placed between the mental foramina. Then the Brazilian group Silva looked at the maxilla. They had all on 4 implants and 6 implants, and they loaded it as you see on the screen. What they saw once again was the distal lingual aspect of the terminal implant that takes all the loaded. So that's pretty consistent between the lower jaw and the upper jaw. So if you're going to distribute implants, and you have a cantilever, what they saw was that you double the stress on the distal lingual. So if you put a cantilever on your implant, that is almost trying to ensure the failure of the terminal implants. They also observed in that study that if you do not have an implant in the cuspid position, there will be an increase of up to 30% stress within the framework. Now that's just a number. It may matter in your patient, it may not matter in your patient, but it's just a fact to be aware of. So what they said was, if that's the case, then why don't we place a 5th implant in the cuspid position and a 6th implant in the other cuspid position? So if you're going to place 6 implants, it has to make sense why and where it's being distributed. And what the last conclusion or recommendation in that article was, eliminate the cantilever. All right, so we go now to the Italian group that looked at the same thing and saw that if you have a cantilever on the distal implant, there's a lot of stress at the bone implant interface. And if you tilt the implant and you get rid of the cantilever, there's a tremendous reduction of stress, not only at the bone implant interface, but also at the abutment prosthetic interface. So if your abutment screws are loosening, or they're fracturing, or the prosthetic screws are loosening or fracturing, and I have had 3 cases of where the framework is fractured, is not by accident, it's overload. So you have to be aware and figure out why there is an overload. So why do we tilt implants? It's not because it's vogue or it's sexy, it's because you want to get rid of the cantilever. There's only one reason we tilt it. We try to get the biggest AP distribution, and we try to eliminate the cantilever if possible. So that's why we use tilted implants, we use zygoma implants, or whatever the case might be. So if we understand that, then what is this? This is what I just took in the last month from the internet. So it's 2019, and we're asking how many implants should we place. Brånemark said in 1968 that there is no difference in the maxilla, 4 or 6. There is no difference in the mandible, 4 or 6. And we're still talking about this in 2019. And the tendency to put more than 6 implants may be questioned. The ITI consensus that Dr. Polido was also a co-author on looked at the same thing and said there's no need to put any more than 6 implants, and that was published last year in 2018. So if we have a non-resort bridge, this is a class 1 non-resort bridge, the black dotted line represents where the implants should go. And this is the teeth, and the red dotted lines represent where the screw access channel should be on a screw-retained fixed prosthesis. So we're going to now use the biomechanical principles that these authors have taught us, and we're going to place implants in the anterior portion. Then we're going to go as far back as possible and put implants in the posterior section, trying to eliminate cantilevers. And we go to the cuspid and put implant number 5, and we go to the other cuspid and put implant number 6. Now that's in somebody like me who has no periodontal disease, who has no bone loss. That would be the distribution that scientifically has validity. Now, if you have a little bit of resorption, the red dotted line, the curvature of the teeth does not change. The black dotted line, the jaw shrinks medially and posteriorly. That's why the black dotted line is not superimposed on a red dotted line anymore. But the distribution of the implants don't change. Now you start dealing with more resort patients, you go ahead and you put your anterior implants in. And then you go ahead and put your posterior implants in, and you know you should have an implant in the cuspid, and you look to see you already do. And then the other cuspid you already do. So the reason why in a severely resorbed case 4 implants work is because the anterior implants have dual function. They're the cuspid implant in lateral excursions, and they're the anterior implant in the AP distribution. What cortical bone likes is cancellous bone and blood supply in between, not titanium. So trying to fill the cortical bone with titanium is probably not the best idea. So the question is the 4 implant design here better than the 6 implant design? Well, if it's a cantilever like this on the 4 implant system, of course not. But if we move the posterior implants back and eliminate the cantilever, it's probably equal. So when we have a resorbed maxilla or pneumatized sinus, we try to use the bone that's available, and we have this tilted concept. And this has been studied multiple times and with very good authors in excellent journals with a 95 to 98% success rate. So it's nothing new. And Kirkmanoff's article is what I like to highlight because he said that there is no difference in loading of axial versus tilted implants in vivo as well as in vitro, but the only thing that must happen is there has to be cross-arch splinting. So if we're tilting implants, we have to maintain cross-arch splinting, and that's the key to success. And maintaining cross-arch splinting is always discussed as if it was a concept at time of surgery. It's a concept for maintenance. If we want these cases to be successful over the next 10, 15, 20 years, we don't just take off the prosthesis every 6 months and clean it. Because those of you who've done a lot of these things, when you take off that prosthesis, usually there's not much happening there. What you want to do is make sure the prosthetic screws are tight, the abutment screws are tight, and if they're not, you want to identify what is causing their looseness, which basically is overload. So the number of implants, distribution of implants, and rigid cross splinting, this is the simplest laundry list of rules that I've ever seen. But what's important about these is these are dogmatic. You cannot alter these things, you cannot modify them, and as long as you follow these instructions, that's why I'm not any skilled or any smarter than anybody in this room. The success to my last 25 years of immediate loading has been following these rules and being Brana-washed and dogmatically following them. So with the end in mind, let's take a look at a couple of cases before I finish. This is a patient, this is my first BLX ProArch case that I did, and I usually choose the most extreme cases when I'm looking at something, because if it works in those cases, it should work in the regular cases. When you look at this patient, she has a terminal dentition in her maxilla, and it doesn't look so bad when you look at it grossly like this. But if you get closer and look, she has quite a bit of bone loss, and when you flap it, there's a significant amount of bone loss. So you need something that will be quite stable in minimal amount of bone. The upper left quadrant presents with the same issues, and if you take a look again, a lot of bone loss in that area. So we debride the area, we follow our treatment planning, we want to get 2 implants in the anterior, zone 1, we want to get a tilted implant in the posterior, try to get the biggest AP distribution we can. So that's our goal. We remove the teeth, we do our alveoplasty, and we try to place our implants as distributed right here. That's our aim. So without an implant that is compressive and quite direct in placement, it is very, very hard to achieve the stability in this kind of a situation. And if you can do it with the BLX, which we were able to do, then confidence is quite high in using this implant on this type of cases. I take a lot of intraoperative x-rays to make sure that I am where I want to be. And then another feature that should be highlighted is the platform switching type of a concavity in their abutments, which gives a much thicker and wider soft tissue base isolating the abutment implant interface from the oral cavity. And these are tightened to 35 Newton centimeters, and all my cases are immediate loaded. So the denture is converted into a fixed provisional hybrid and allowed for 6 months to heal in the maxilla before the final prosthesis. And this is what the patient looks like 1 week post-operative. Now, what's important about these type of patients are they have never been edentulous. The lower was treated by somebody else, but it was immediate also. So these patients never experienced a denture in their mouth, so it's a very different patient than this one. This is a 92-year-old, extremely active woman who wanted to have a fixed prosthesis in her mandible. We used co-diagnostics, and we fabricated, my son Armand, who's a prosthodontist, fabricated the upper immediate denture and the lower immediate denture that will be converted into a fixed provisional, took out the teeth, alveoplasty, and then immediate loaded this particular case. So very, very predictable in the lower jaw also. This was my first lower jaw that I did. And then it was restored as you would traditionally with the corrected cast technique of your choice, and then making sure that you have the wax up, and then digitally having the framework designed by the Straumann Group in Texas, in the US, and then having the framework try-in, making sure an absolute passive fit on all abutments, and then the final prosthesis is delivered. Now, the occlusion, group function on both sides, and then teaching our patients how to maintain these things. What is important in this particular case, not only it's a double jaw, but for some reason, this patient, he's a very educated, very wealthy guy. Why he's like this, I'm not sure. I'm sure you all have patients like this. But for some reason, teeth are not his priority. All of these teeth are coming out, and he's really a tooth-only defect. He's a white bridge. The surgical fee is not different, whether it's a white bridge or a hybrid. The prosthetic fee is considerably different if it's a hybrid prosthesis versus a white bridge. So he chose to have a hybrid because of the lower cost to him. And what I want to share with you here is, well, with end in mind, we have to understand what we're doing. We're going to do a hybrid. So what is the inter-arch distance that we need, which is a point of always discussion. If you have a missing tooth only, such as him, and if you were going to do a white bridge, all you need is 10 millimeters of inter-arch space. But if you're going to go into the hybrid prosthesis, now you need inter-arch space, a space of 14 if it's a zirconia bridge, 16 if it's a titanium reinforced hybrid, and 18 if it's a metal reinforced. So the inter-arch space has nothing to do with all-on-4 or zygoma or ProArch or tilted implants. It is a function of what is the final materials that are going to be used to make the prosthesis. There is no framework in the zirconia, so it has a shorter space than the soft gold bars that have to be much thicker. And in this particular case, we go ahead and do our tilted concept in the maxilla, tilted concept in the mandible, as you've seen here, making sure we have the adequate inter-arch space. For a titanium bar, teeth are taken out, alveoplasty, and direct conversion of the dentures into a fixed upper-lower provisionals, ensuring that you have good group function. And this patient, once again, does not experience a removable prosthesis, which is what the goal of most of these patients are. One of the most, and I've been doing this with other companies for again, over 25 years, but the BLX for me stands out because of its platform. It relieves the stress from the surgeon on the diameter of the implant that's being used for getting initial stability. For instance, if I was planning on placing a 3.75 millimeter in that last case that I showed you, and I was not getting initial stability, then I would automatically change it to a 4.5. If I didn't get initial stability for some reason, then I would automatically change to the 5.0. But with different systems, I would say, I got to stop, because there is no angulated abutments for anything that becomes 5.0 and up. But in the BLX, because of the single connection, that's not a problem. And I think for the surgeon, clinically, that's a tremendous stress relief, knowing that you can get your surgical stability without having to worry about creating an environment where the restorative doctor cannot do their job. So in conclusion, proper number and distribution of the implants, I think that cannot be more reinforced. Cross-arch splinting. You have to have a pragmatic follow-up for your patients. And once the final prosthesis is made, I would like you just think to yourself, what is your follow-up? Usually I hear that the hygienist or the assistant takes off the bridge, they clean the bridge, they put it back. I think that's not fair to the patient, that's not fair to you. I think that if I was a restorative doctor, I would remove the prosthesis, making sure the prosthetic screws are tight or not, the abutment screws are tight or not. This way I have control of what's going on. Because the long-term success, the immediate success of immediate loading is cross-arch splinting and getting initial stability. Long-term success is maintaining the cross-arch splinting, and what that basically means, tight screws. Balanced occlusion, and then educating your patient. Spending the time saying to this patient, you have a diamond in your mouth. You spend 90% of your day socializing, speaking. You're not worried about your denture falling out. You have nice lip support and facial form. Appreciate what you have, and don't go and eat a raw carrot. There has to be a limitation on what you can do. Well, I want to eat a raw carrot. Well, I want to have a jumbo jet. I mean, what does that mean? So we have to take the time and make sure we communicate with our patients and make sure that they understand, and we have done our job educating them. God gave them teeth, and they managed to destroy it. I don't think we are better than God giving him this set of teeth. And then the last thing, which is really out of our control, is patient compliance. If the patient does not follow the instructions, then that's their issue. So with that, thank you very much for your time.
Perfect. Good job. Well, thank you, everybody. Thank you again for excellent. One more round of applause for the excellent speakers for today. Thank you, everybody, for staying up so late. Go and carefully select your patients. Enjoy the new portfolio for the BLX. But before that, enjoy some really nice Portuguese wine tonight. Thank you very much.